Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, die Österreichische Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse, Transplantation, and the Junge Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Dr. Swapnil Hiremath in Ottawa, Ontario, Canada, with whom we would like to discuss the renal risks, if any, of contrast media in patients with chronic kidney disease. Dear Swapnil, it's a pleasure to host you for a third time at Marcus at Home. Welcome back.
Thank you. I'm happy to be here.
Dr. Swapnil Hiremath is a staff nephrologist at the Ottawa Hospital in Ontario, Canada, a professor in the Faculty of Medicine at the University of Ottawa, and also an associate scientist in the clinical epidemiology program at the Ottawa Hospital Research Institute. His work is characterized by a commitment to evidence-based medicine, aiming to replace clinical myths with rigorous data to improve patient outcomes in nephrology and hypertension. He's internationally recognized for his evidence-based research into contrast-associated AKI, where his work has been instrumental in re-evaluating the actual clinical risks of intravenous contrast media. Moreover, Professor Hiremath is a well-known superstar in nephrology, being co-creator of NephJC, a panelist on the Freely Filtered podcast, and editor-in-chief of the new journal, Kidney International Case Reports. It's an honor to have you on again. Thank you.
Thank you. Awesome. So I'll use this opportunity to share some of my thoughts about contrast nephropathy. I come from the beautiful city of Ottawa, and this is one of the nice pictures that I could get from the city. And again, we are using a pun to say what is left to enhance on contrast and the kidney. In terms of my disclosures, I do have some research funding. The CI-HR is for research in contrast. And I am the co-chair of the Canadian Association of Radiology guidelines, which I'll show briefly, but my opinions here are personal. They do align mostly, but my opinions, especially the stronger opinions, are my own. So the objectives that I set for about 30 minutes is to describe the mythology of contrast nephropathy and understand what works and what doesn't work to prevent this, if at all we believe this exists, and some practical discussion. And I would love to have some discussion afterwards on these thoughts. So you might say, you may hear about this, and papers are still written like this, where the paper will start as contrast-induced AKI is the third most common cause of AKI. There are many papers that have been written like this, which start like this, and it is still something you might see. On the other hand, there are other physicians who will say, especially intensivist ER doctors, who will say it's a myth, right? It doesn't even exist. There is no such thing as contrast causing AKI. So how do we, this is East and West, where should we meet? So where does this whole third most common AKI come? And if you look at, you have to trace the citations, because, people will often cite a review paper. And if you say that will cite another review paper, but if you dig deep down, this is the paper where it all began. It's by Susan Hu from Boston, where there's, many, many decades ago, who talks about this. And if you read that paper, it is a prospective study of 129 people with AKI. At that time, they called it acute renal insufficiency. And out of that, 16 of them had contrast. So, there have been 16,000 papers written saying contrast is the third most common cause of AKI on the basis of this data, which has 16 patients. And this was in 1983. So, more than 40 years ago. At that time, they mostly use high osmolar contrast dye. At that time, they had no idea that contrast can even cause AKI. So, it was been given in whomever. There was no concept of CKD staging. So it's quite likely that some of these patients had advanced CKD. And there are no control groups. So we don't know if the patients would have got AKI anyways. So this is the sort of basis for that third most common AKI, which you should completely disregard. If any paper starts like that, don't read it. They don't know what they're talking about. On the other hand, why do I say control groups are important? It's because contrast can cause AKI. And often it's like, our fellows will often go, our residents will go and see a patient. And they will say, oh, the patient had, cardiac cath 3 days ago, or they had a CT scan. And they'll say, oh, yes, that's the smoking gun. The contrast caused the AKI. But if you see, they got the CT scan for a reason. Maybe they had abdominal sepsis, and it's the sepsis that caused the AKI. Or they had an MI and they came in cardiogenic shock, and sure, they had an angiography done, but it's the shock that caused the AKI, and the contrast is just a bystander, which is why the terminology has now changed to, people either call it contrast-associated AKI or they call it post-contrast AKI. And you're free to use whichever terminology. Again, post-contrast AKI is non-judgmental. It doesn't say whether it's associated or induced. Contrast associated is often used nowadays, but again, that also means you are bringing the contrast in, and whether it's an association or causation, it's a little bit murky. So these are the terminologies, but contrast induced is you have to really be sure that it was induced. But then let's go back to this myth. Josh Farkas, he's an intensivist from Vermont. He writes this beautiful blog. I really like him, but he says it's a myth. It doesn't even exist. So, and my career is made on this area. Was I just a historian and not a real scientist? So how do you prove that a black swan exists, right? You see a black swan and you can say, hey, there it is. So this is a patient that I saw a few years ago. This is a plain CT scan. This is not a contrast CT scan. And what you see here is what is called as a nephrogram. So this is a nephrogram you see because the patient had contrast 3 days ago, and he came in with anuria a couple of days later, right? 48 hours actually. And what happened here is you see this patient's creatinine. This is in the reverse chronological order. So, it was the baseline creatinine was about 180. Then after they got the contrast on March 11th, it jumped up to 250. And then a couple of days later, this was a staged procedure. So they had another angiogram and a stent put in, and then it goes to 400 and 600, right? So this is what was going on. They had a cath, and then they had another cath, cardiac cath, and they had 2 contrast exposures. And it was a complicated procedure where, they had a previous CABG. So about 300, 400 ml of contrast was used. So it was a large dye load, and it was 2 contrast loads. So that's sort of what you need to see to call it truly AKI. And this case is from 2008. This is because we don't see this often. If I had a case happening this month, I would have shown that one, but we don't. So, true contrast AKI, very, 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 very uncommon. It often is seen with people who have low baseline GFR, who get a very high contrast load, often arterial. And often you see this with, let's say there's a stroke where they will have 2, 3 CT scans, an angiogram or whatever, or like something like this, where they have an angiogram, another angiogram, and they would present with oliguria, rapid creatinine rise, often with volume overload, but they always recover. Almost always they recover. So these patients, they are very uncommon. Maybe we have a large cardiac center. We see maybe once in 2-3 months. That's the frequency, right? It's definitely not the third most common cause of AKI. If you're an ER doctor or an intensive care doctor, you should not even think about it. Even if you're a cardiologist, go ahead and do this, right? It's such an uncommon disease. You have to fix the patient's heart, fix it. Don't worry about contrast AKI. That's my thinking. And if you don't see a recovery, you think about something else, which we'll come to. So why do some people think it's a myth? It's because of all these papers, right? And again, I don't want to diss them. I think these papers, many of them by Jennifer McDonald and colleague from the Mayo Clinic. This is a Canadian paper. They are all good papers, and they were important because they could push back against this third most common cause of AKI, do not give contrast mythology. We needed that. But now I think the pendulum has gone to the other end where people say it doesn't even exist. So I would push back a little bit to say when it doesn't exist, because if you look at this sort of a patient, let's say there's a 75-year-old woman whose baseline creatinine is about 300, GFR is pretty low. Many of us will think long and hard before we do a contrast CT scan or before we do an angiogram in this patient. So what happens is when you do a large database study, these kind of patients are underrepresented and they go into the control group. They don't go into the contrast group, they go into the control group. And their risk of AKI is high, whether they get contrast or not, right? If they get sick, they're likely to get AKI. And that's what will push this propensity score match studies towards the null. So that's where you have to be careful about it, not over-interpreting these. And so as an example, in one of these studies, if you see this last group of patients with a GFR less than 30, there does seem to be a high risk. But then again, be cautious because this is an observational study. There may have been other causes of AKI going on. And the overall study had, 20,000 patients, but you have about 100 patients in the GFR less than 30. So it's a very, very fragile result based on very small numbers, because mostly when the GFR is 30, A, very few people are there, and B, we are very careful about using contrast in those patients. So I'm not I cannot confidently say that in patients with GFR of less than 30, there is a risk of AKI. But I would say that in those patients, you should be a bit careful and you should think before you give contrast. Not that you should not give it, but think, is it essential? And then do it. So it's uncertain. So I don't think it's a myth, and low GFR is a risk factor, but it's extremely uncommon. And if you see as what, if I say it does happen, what is the cause of AKI? And you will see something like this, which I think is totally unhelpful. You know, there are arrows going in all sorts of directions. And when you see a very complicated flow diagram like this, it's trying to hide the fact that we don't know, rather than tell you what is going on. In my opinion, you know, I would go back to this nephrogram that I showed you. This is a patient who actually had what I believe was contrast-induced AKI. So this contrast dye, you know, it is colorless, but it is pretty viscous. And it is, even if we call it low osmolar, it is higher osmolar than, you know, serum osmolality. What happens is it mostly gets filtered in the kidneys. And because of its osmolarity, as the water is getting reabsorbed, it gets concentrated in the tubules. So, you know, the flow of urine is slow in the tubules, and it's actually physically clogging up the tubules. There's also some of which doesn't get filtered, so it goes into the efferent and into the vasa recta, where it may also, you know, slow down the blood flow, possibly cause some medullary ischemia. So I like to think about it as this physical intratubular obstruction, which is why the contrast is stuck in the kidneys. You see it in the nephrogram. And that's why, you know, when it gets flushed out, the patients recover. If it is actual acute tubular injury that is happening, it's not going to get better in a week. And typically you will see patients who are truly contrast-induced AKI, they get better in a week. As soon as the contrast is gone, they are fine, they bounce back. If it is tubular necrosis, you need the tubular cells to heal, and that will be a, you know, process that takes a few weeks and not a few days. So, you know, that's the reason why, again, the dose of contrast or repeat exposures, or when you have advanced CKD with fewer nephrons, that sort of all makes sense, right? It's a coherent story. And that would also be why arterial contrast would be worse than venous, because, you know, if you're doing a left ventrilogram, you're doing an aortogram, it's reaching the kidney in a concentrated fashion rather than, you know, getting diluted in the systemic circulation. People would argue, of course, though, with cardiac cath and coronary angiogram, it's going into the intracoronary, which is sort of like more like venous, right? Because it gets diluted. So it's not really arterial. So it's only if you do the left ventriculogram or an aortogram that cardiac cath would be worse. But we do see a higher risk with arterial than venous. So even with just coronary angiogram. So what might be going on there? So this was actually an actual RCT where they did IV versus IA contrast. And where they showed that, yes, the risk of AKI was higher with the red. You know, the red is the arterial versus the blue being venous. And they call it contrast-induced. But you see at the risk factors, sure, ventriculography was worse, which is like, you know, arterial contrast. But a femoral axis was worse than the radial axis. Now, if it is contrast causing damage, why should a femoral axis be worse, right? It's just the contrast, radial axis, femoral axis, it should be the same. And the answer lies here. So this is from the Renal Fellow Network blog. What you're seeing here is a cholesterol crystal. The transparent things is because in the processing of the tissue, the cholesterol dissolves. So this is sort of what is happening is when you go through the femoral artery, you're dislodging cholesterol emboli, and some of them go into the kidney. And then you're calling it contrast, but it really wasn't the contrast. It was the wire which is causing the AKI. And this was a really cool Japanese study where what they showed is that they measured they had, you know, these are patients undergoing a TAVI, a transcatheter aortic valve implantation. So every patient who undergoes a TAVI has a CT scan. So with the CT scan, they measured the atheroma burden. And what they show is that the atheroma burden above the renal arteries is associated with AKI, but the atheroma burden below the renal artery is not associated with AKI, which is telling me, you know, again, if there is atheroma below the renal artery, it's not going to embolize into the kidney. It will embolize into your feet, right? So this is not contrast. This is atheroembolic disease. And a bunch of the arterial contrast is not because of contrast, it's because of cholesterol emboli. So I think it's, and again, also it's also ATN, right? Like, because these patients, if they are coming in shock with an MI, that's going to cause the AKI as well. And the contrast is not doing anything. So after arterial contrast, we do say that the risk is probably 0 with venous. Maybe it's really low with arterial, but that really low only a small portion is contrast. A bunch of it is ATN or a thromboembolic disease or something else. And this is the most famous risk score from Columbia that everyone quotes. But if you look at that risk score, the risk factors are older age, diabetes, heart failure, higher creatinine. So if you look at an average patient in the hospital, these are risk factors for AKI. There is nothing special about contrast here. So they are really picking up the risk of AKI. And then two of the risk factors which are highest are requiring an IABP, an intra-aortic balloon, and cardiogenic shock. And I would argue that these two risk factors actually cause ischemic acute tubular necrosis. They are not causing contrast AKI. So this risk score is basically predicting the risk of ATN and not CIN. Sure, it is AKI, but label it as such, right? Okay, this is a fantastic risk score for predicting the risk of AKI with cardiac catheterization. But that doesn't mean it's contrast. And don't use it to justify, oh, I will use contrast or I will not use contrast. Even if you don't use contrast, the risk of AKI is high. If you have cardiogenic shock and IABP, are you surprised if they get AKI? No, it's ATN. It's not CIN. So you could think about it this way, right? After an arterial contrast, there is a small risk of, of all the people who get AKI after arterial contrast, it's mostly ATN, it's mostly a thromboembolic injury. Maybe, they got some drugs or whatever else that is causing AIN. And if you think of venous contrast, I could not make that dot any smaller in PowerPoint, but if it was possible, I would have made it like a very, very tiny dot. To be honest, I have seen one case in my lifetime with venous contrast, which I was convinced there was nothing else. So it's very, 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 very uncommon. And if the intensivist or the emergency doctor wants to say it's a myth, go for it, right? I don't think you should really worry about contrast with venous or CT scans at all. It's like a case report that you publish kind of a situation. What about residual kidney function? We have patients on PD, especially who have residual kidney function. And then there are, they need a angiogram and the cardiologist may say, no, they are making urine, I may damage the kidney. We did a small systematic review. Again, this is very poor quality data, 9 studies with a small number of patients. We didn't show much of a difference in residual kidney function in this study. So if patients on PD or with hemodialysis have some kidney function left, they need an angiogram, go for it. And this is the reason why I think it's important to think of the definition is this was a really nice study from the Preserve where they looked at, this was the RCT of, saline and NAC, but in this sub-study, Chirag Parikh and colleagues looked at biomarkers. And there were patients who had AKI, they call it contrast-associated AKI, and those who did not. And what they basically show is that in this study where it was patients with angiography, if they had AKI, the tubular injury biomarkers did not go up. So there was really no tubular injury. And most of the AKI that happened was, just noise, was hemodynamics or pre-renal or what have you. And it wasn't really true tubular injury that is going on. So, again, most of these studies, we say, oh, this is, this was the incidence of contrast AKI. It really was not contrast-induced AKI. It was something else. So, and if you look at the KDIGO AKI stages, right, 50% rise or 26 micromole rise is called AKI. But if you look at this, it's 26 micromole. It happens if in a hospitalized patient's creatinine goes up and down all the time. If you measure this in a database, you're going to get a lot of AKI where the contrast has nothing to do with it. It mostly picks up noise and inconsequential AKI. And in a large trial, again, people say, oh, you get a lot of events, so you get a lot of power in your trial. But I would argue that it's actually picking up noise and it will make your study worse, right? You want to pick the specific cases where it's truly contrast rather than pick up, a lot of other noise that is going on. And maybe that's why it's hurting research, right? Where you see a negative trial when maybe there is something going on. And it's not KDIGO's fault, right? This was Rifle, it was Akin, and before all these things were established, people would call whatever 50%, 100%. There were all these many other definitions floating around. So the standardization was helpful, but that softest definition of type 26 micromole, I don't think personally is very helpful. We proposed, JC Velez and I in a review paper, we proposed, this was sort of like the infective endocarditis criteria, where we said you need to have essential criteria, and then you need major criteria. Because in CIN, they always say, okay, make sure you rule out other causes of AKI. But when you look at this large database, they have no way of ruling out, sepsis, hypotension, nephrotoxins, are there cast, whatever, So we made up these criteria. Again, this is opinion-based. We haven't validated these definitions, but this was sort of, a clinically useful way of saying, hey, use this. And if you use this, I'm sure you will find very, very few AKI, a contrast AKI. You will not find zero if you are in a large nephrology practice, but it'll be very few, maybe a few a year. And it's really not a big problem at all. So just to summarize so far, it's not a myth. I think dose of contrast and low GFR matters. You will see more with arterial, but it'll be a mix of many things. It doesn't matter for residual kidney function, and it's mostly noise. So I think, it's fine to give contrast. And if you're calling it CIN, it should be a careful clinical diagnosis. But let's go back to this, even if it is not zero, if it's low risk, how can we make it even lower, right? Again, I'm a nephrologist. I shouldn't say who cares about kidney injury. We should try to prevent it if we can. And if we look at this nephrogram, again, I'm showing it this for the third time. If this is the etiology, maybe hydration could help because we are diluting the contrast. But if you look at the trials, this is the amazing trial. The Netherlands showed no difference. This was, of course, patients who had a GFR of 30 or more, and whether they were having an interventional procedure or not, it didn't seem to make any difference. There was a similar trial with Compass. In amazing, it was saline. In this case, it was bicarbonate. No difference at all. The only thing is that in both of these trials, the GFR was more than 30. So people would say they were low to intermediate risk and not high risk. So in GFR of less than 30, you could argue there is some wiggle room if you really believe in hydration to still do hydration. And there is, so you could argue that in these patients, especially if you're using a high contrast, low GFR is less than 30, it's an arterial contrast. Maybe there is some justification because no one has disproven that hydration does not work. So excuse me, you could justify that. Because the previously discussed RCTs were those in GFR of more than 30 or intra-arterial contrast. So in these situations, could you do hydration or something better? Now trials of hydration are going on, but there are these kind of trials where they use LVEDP, guided hydration, where they looked at the LVEDP and based on that, they gave more volume or less volume. Then they look at the urine flow rate and based on that, they give more volume, less volume. And there are these, meta-analysis, but again, they are small single center RCTs. To be honest, if your cardiologist is keen on doing this, go for it. We don't do it locally. I think the risk is so low that, going to find an improvement in such a low risk is going to be very hard and hard to justify, spending more money doing more interventions for this. It does take more time, right? So your patient is going to spend more time in the cardiac cath lab to measure the LVEDP and do these things. But if you have a patient who's very, very high risk, you're convinced that something bad is going to happen, sure, you can use this. Bicarb versus saline, we don't need to belabor this. The PRESERVE trial was, 5,000 patients, showed absolutely no difference. What about oral salt and water? These are, this was a systematic review we did, small number of trials. Oral salt seems to be as good as IV salt, salt and water. And the reason I like this is because if let's say you're doing a CT scan, if you're doing a cardiac cath, it's usually, in my center, it's usually easy to arrange for IV volume expansion. But if I'm doing a CT scan, it's hard for me to arrange for IV. But you could just tell the patient, hey, have some chicken soup, salty chicken soup, and drink a bunch of water. And maybe that gives a little bit. And that's an easy, cheap, low-cost intervention you could do if IV is hard. Again, not a very robust result, right? So it's not a very strong result. So for prevention, above GFR of 30, low risk venous, who cares? The risk is like pretty close to zero. Below GFR of 30, some volume expansion could be considered. And if you cannot do IV, oral may be enough. But if you don't do nothing also, I think that's fair, right? The evidence for doing something is very, very low. What about dialysis after contrast? This is the question. I don't know about you. We get asked all the time. It is so foolish because the contrast that goes in one cardiac cycle, it's gone to the kidney, right? So to do a dialysis 2 hours later makes absolutely no sense. But there are some trials, and I like this one, which showed no difference. Somebody actually did a trial, shows no difference. And if this is in a patient who's on dialysis, right? Imagine if you're being asked to do dialysis in a patient who is not on dialysis. The risk of doing, a catheter and dialysis and hemodynamic is far worse than whatever is the risk of AKI. So, and physiologically, it makes no sense, right? What about safer contrast dye? People confuse this sometimes. So the high osmolar contrast dye are worse than low osmolar contrast dye. And this was from a meta-analysis, many trials done more than 30 years ago. Right now, no one uses high osmolar contrast dye. We use low osmolar or isoosmolar. But you see the low osmolar also, they are not lower. Their osmolality is about 600, which is twice that of, serum osmolality. And there are some mixed results. Some people claim iodixanol is better than iohexol. But if you look at the totality of evidence, it mostly seems that low osmolar, isoosmolar are similar. And it mostly doesn't matter. And these are the contrast dye that are used mostly across the world. So, dialysis is silly. It is futile. Don't talk about it. Isoosmolar is similar to low osmolar. What about holding nephrotoxins? So, metformin, I don't know about you, but we still get asked this all the time. But metformin does not cause AKI, right? You know all this. What happened is that there were a few cases where patients were on metformin, they got AKI, and the metformin was not stopped. So you're having a situation where patient has rip-roaring AKI, they're still on metformin, they got lactic acidosis. So now they're saying, oh, if the patient is on metformin, you cannot do a contrast scan and stop it for 2 days before, which I think is so silly. In GFR more than 30, who cares? The risk of AKI is very low. GFR less than 30, you should be careful anyway about using metformin. So think about it and follow them. And if they get AKI, stop it. But it doesn't do anything. It's all, this is mostly the American medical legal system that has created this mess. Metformin is a great drug. Of course, now we have many other drugs. So, I think this is a non-issue. It's just a nuisance. Other drugs, there is a trial on the RAS blockade, stopping or continuing ACE inhibitors, ARBs, absolutely no difference. So, I don't think there is any difference. Diuretics, should you hold Lasix if they are on Lasix? If you believe hydration helps, then holding Lasix would be helpful. But the way I would think about it is it's more about what is the actual need for Lasix. If the patient is volume contracted, you should not be giving them furosemide anyways. If they are volume expanded, you should be giving them furosemide, whether they need contrast or not, right? So look at the clinical situation rather than the risk of furosemide and AKI. There are many other things that don't work, and I'd like to wrap up now. I'm coming at in the half an hour. I'll just mention this trial because, and it was Gunnar who pointed this out to me when it came out. The nitrate CIN trial. This was a 600 patient trial, large trial. They looked at, double blind, and they showed this dramatic effect. I'm a bit skeptical, and this is why. So it was single center, and I don't go into N-acetylcysteine here, but the story of N-acetylcysteine started with a single center trial. So we need replication before we go ahead with that. It was double blind, which is good, but they call that outcome as CIN. And if you look at what they did, they used the KDIGO definition. So, and they're 30% CIN. If 30% CIN after a contrast procedure seems very high. After angiogram, this was cardiac angiogram, seems extremely high. Like a third of the patient are getting AKI. That's very high. To me, they're mostly picking up noise or, or pre-renal factors or hemodynamic stuff. If this was the real incidence of CIN, we would all be extremely busy doing, dialysis and what have you in our cardiac centers. So I suspect most of the cases they are calling CIN, where, ATN, atherembolic disease or hemodynamic or whatever else was going on. And nitrates might be doing something, right? Maybe nitrite is doing something to the cardiac function, because how do you explain, cardiac events are halved at 1 year. If you're reducing AKI, why are the cardiac events better at 1 year, right? Many of these benefits seem way more than what one would expect to see just with CIN. So to me, this seems to be something systematically was better and not just because CIN gets better in a week, right? So why are you going to see these long-term benefits? Either, the protoplasm of the patients was different somehow, or, nitrates are really good, but I wouldn't say that the mechanism of the clinical benefit of nitrates is through the CIN pathway. It is probably through the cardiac or, hemodynamic pathways. But that's my speculation. I would love for a larger replication of this trial. So to finish off, I will plug our guidelines. We have this really nice algorithm. I really like it because we say, hey, is the patient sick? Do they really need the contrast procedure? If so, forget about measuring creatinine. Just go ahead and do it. Don't bother measuring creatinine, right? If they are sick in the emergency, if they are critically ill, or if they need a therapeutic procedure, right, with contrast, just go ahead. If not, sure, take time, do a creatinine, risk stratify, decide if you want to use it or not. Because that's most of the nuisance, right? That happens is, should you use contrast? Not. Do you want nephrology to give clearance and all that silliness? And this is a nice visual, element. If you want a one-pager to put up somewhere, you can use this, made by Divya Bajpai for us, which is I think, just walks through the whole guidelines in one figure. These are the references, and these can be, I can make them available for people who want them. I'll again give a plug to our podcast and say, all of you, any nephrologist, you should be a flozinator and a GLP-1ator. And I'll stop there. And I'm happy to have some discussion about these strong opinions.
Thank you so much for your amazing presentation, Professor Hiremath. I would like to start off the discussion with a question on terminology, because you have used contrast-induced AKI, but we have also previously heard contrast-associated AKI. Maybe you can explain the differences and which one we should be using.
Yeah, so I am not a big fan of contrast-induced AKI, unless you're really, 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 really sure it is contrast-induced AKI. Right, especially in the clinical chart, so there is in the clinical chart and in the literature, right? In the clinical chart, it's possible for you to figure out by saying, okay, they don't have sepsis, they did not get, vancomycin, and they were not in shock, and there was nothing else going on, and oh, the patient is, oliguric, and they got a large diload. Sure, then you can be then I'm sometimes say these are the ones in 2-3 months that I feel confident. I say this is most likely to be contrast-induced AKI. That's the best I can say. Sure, if they get a kidney biopsy and you see the typical osmotic changes and all, sure, go ahead and say this is contrast AKI. That's the best I can say. Otherwise, to me, contrast-associated AKI in a clinical chart is a cop-out. Right? It's you're being oh, I'm playing safe. Maybe it has something. Be confident. Say this is ischemic ATN. This is at least what I teach my fellows. Calling it contrast-associated AKI is not helpful to anybody, right? Because what is the cardiologist going to think? Did I do something wrong by giving the patient contrast, right? What does this associated mean? Be confident in saying it's contrast-induced AKI in those rare cases, but in everybody else, say that it's very unlikely to be contrast. It's probably ATN, or it's sepsis, or it is whatever, right? Sure, if you have a differential diagnosis list, you can put it at the bottom. But if you call it contrast associated in a clinical chart when you're seeing a patient, I think that's a failure of your clinical reasoning. In the research literature, though, it's a different story, right? Because you don't have all the facts. You're doing an observational study. There, I think it is fair to call it, contrast associated AKI, because you don't know, what else was going on in the chart. Or call it post-contrast AKI as well. But over there, you should be extremely careful, right? Because you are very unlikely to be confident that it is contrast-induced unless you have a biopsy or like a clinical, like in trials, right? Where somebody actually looks at the chart and does adjudication. So that will be very, very low. And none of the, those propensity score math studies are like that. So for them to say contrast-associated is very legitimate. But in the chart, if my fellow writes contrast-associated AKI, I give them a hard time.
Thank you for the explanation. And since implementing the guidelines in Canada in 2022, have you seen a decrease in renalism in Canadian hospitals, or are you still discussing with radiologists as we do in Austria, unfortunately?
So at my institution, what I can tell you is that has gone down a lot. The renalism, so the renalism for the viewers is this therapeutic nihilism in the renal patients, where unfortunately, so Glenn Chertoff from Stanford coined that term many years ago. And especially, when I say it's the CKD patients, they often will not get CT scans. Their diagnosis will be delayed. They won't get angiogram. Their arteries will not be fixed because they have got CKD, right? And that's a disservice, because CKD patients are more likely to die of cardiovascular events. And by not even diagnosing or fixing them, we are doing a disservice to them. And even cancer is so common, right? And how do you diagnose cancer? Often with a contrast CT scan. So at our institution, we really worked hard on the implementation. I don't think guidelines are sufficient. Guidelines are necessary, but they are not sufficient. You have to work at an individual institution level. So we met many times with the radiologist and with the emergency ICU physicians as well. They are on board. They like to give contrast, but it was the radiologist and the cardiologist, and we all agreed. We still occasionally, right, there is some new person trained somewhere else who comes in and who raises this. But it's much less common. So I think locally we have managed to do this. Nationally, it's been only centers where there is a local champion. Because I get these questions from other institutions, from radiologists, and I tell them, you have not seen, these are not nephrology guidelines. These are the Canadian Association of Radiologists guidelines. Please read your own guidelines. So this is a problem we do face at every institution. So I think this is not a problem that can be solved with guidelines or you and me talking at a webinar. It has to be like a local implementation level. It's the hard work of meeting with stakeholders at your institution and convincing everybody. And it takes, we met like 10 times over a couple of years to hash out all these differences. And we promised the radiologist that as nephrologists, we would not blame them, right? Because again, they feel the blame, right? They feel somebody's writing in the chart, the CT scan caused AKI. So they feel responsible and they have not made the decision, right? So then they play safe because, they are not taking care of the patient. So as clinicians, I think we also have some responsibility of telling, our community saying, stop calling it AKI from contrast. Don't blame the contrast for every AKI. Because that's out there then, and then the cardiologists, radiologists are going to be like, say, you are the ones calling it CIN. So why I should be careful about giving contrast. So I think it's bidirectional, but it requires a lot of hard work at the local level. So I think so to answer your question, it's still a work in progress.
Yeah, thank you, Swapnil, for your excellent talk and pointing out who were the founding fathers of this religion in 1983, so to say. I'm always surprised and wondering what we are doing, because still in 2026, with all the scientific methods that we have, the scientific rigor, it's still something like a believing and psychological field. We do this day in, day out, also with our radiology colleagues, because there are several parallels, like the 4D study with atorvastatin. It didn't help the patients, but in a survey 2 years after the publication, there was no change in the prescription at this time of statins. So it's obviously harder to leave something in our mind than to adopt something new, picking up, SGLT2s for everybody and so on. Do you envision somehow some kind of definitive trial where we can pull out every question? Because now it's still like the Loch Ness monster. Maybe it's here, it's very rarely seen, but nobody could disprove it. Because if you say, I saw one patient with a contrast-induced AKI, but 40,000 I didn't see, you still have this monster in the room, so to say.
Yeah, no, that's an excellent point, right? And so I think, and the religion, as you say very nicely, at that time they did serve a purpose, because in the 80s, I'm sure people, I was a small child in kindergarten then, so I'm not sure what was going on, but I'm sure at that time they did not know that contrast can cause AKI. So I think at high or smaller contrast, the risk is high. So I think it served a useful purpose then. And that is what led to the creation of the safer contrast dye, and so on and so forth. So I think it was useful, but which is probably part of the, your point that despite the contrast becoming safer, we have been still stuck with the data from the old time, and it was worse, right? In terms of a definitive trial, again, I am biased because I think the definition of AKI is bad. You will still have, again, the nitrite CIN trial from UK, from BARTS. It's a fine trial. Methodologically, there is nothing wrong with it, but their outcome is bad, right? Their outcome, they use the KDIGO definition, and the KDIGO, even the new draft guidelines, they still have the same definition. So if you use this definition, which is not really picking up true contrast-induced nephropathy, you will have some events. And then what are those events telling you? It's just something noisy, right? It's not useful. So to have a definitive trial, I would argue you should use, a very, very rigorous clinical definition of CIN. Then it would be possible, right? And then even a good observational study would be enough to me. Like if you do a prospective study, 10,000 patients, and you use that clinical adjudication, then you could say, hey, the true risk is so and so. And large database studies are just making things very messy.
Yeah, I mean, we published 20 years ago, along with Andreas Wichetil, in peritoneal dialysis patients. They have, a GFR of 7, 8. And if they get high volumes of contrast, it goes down to 5, 6, and then after some days it goes back to 7, 8. I mean, these are really extreme conditions. And what should I make to make it more extreme, so to say? And if this is all noisy, we still have, at least over the whole country, this 30 milliliter cut. So when a patient comes with 29 milliliters, we dilute him up to that he has then 30 milliliters of GFR with 1 liter rengalactate or what else. Yeah, this is current practice 2026, and we all we jump around. Okay, but maybe can you say one or two words to another big thing, which is now, I think, also very noisy. Previous times it wasn't. This is gadolinium and MRI. Can with the new gadolinium dyes, we completely sort out the previously, where we had a lot of horror.
Yeah, exactly. So the gadolinium, again, it's not nephrotoxic, but the linear gadolinium, that Omni-Peak, which was available many years ago, OmniScan, that was associated with this nephrogenic systemic fibrosis. So the condition itself is nasty, right? We had a patient with that, and it causes fibrosis everywhere, scleroderma-like illness, diaphragmatic pleural fibrosis, and it's a really, really nasty course of disease and death that the patient had, and the cases that had. And after a few years, it was an Austrian physician who picked up the MRI gadolinium link.
He did a lot of damage with his observation.
Yes, exactly. But it was a very, very astute observation, and picked that up. And now no one uses that particular gado agent. We all use the cyclic agents. And no cases have been reported in the last, 10 years, maybe even longer. There was a systematic review which also showed no cases. But it goes back to your point about, are we not seeing any cases because we are careful? Because we are careful. Once the GFR is less than 30 or they are on dialysis, especially then, people think long and hard about using GADO. We do face that problem locally also. We have not completely eliminated that. But with our radiology colleagues, they have agreed to do it in dialysis patients to give gadolinium. They do take a pause to think, is this really necessary? But for the liver and for the CNS, central nervous system, you need gadolinium. There is no way often to make a diagnosis without gadolinium. So we do go ahead. They still insist on us doing dialysis in dialysis patients after the gadolinium. Now, this is slightly different than with contrast, because with gadolinium, in a dialysis patient, it remains in the circulation for longer. And hence it can get deposited. And if you remove it, sure, you're removing it faster. But the European guidelines do not say you should do dialysis, because they have seen cases happen, again, this is 20 years ago, even after dialysis. So it's a little bit, we are not sure about the benefit of dialysis in dialysis patients to remove the GADO, because, if you remove it in 3 hours versus you remove it the next day, these patients are mostly on 3 times a week dialysis, right? Does it make a difference? I don't know that it makes a difference. But, the way we operationalize this locally is we schedule the MRI before the patient's dialysis. If the patient is going to have dialysis Monday afternoon, we do the MRI Monday morning, rather than, arrange for an extra dialysis. Is that the right thing to do? Maybe not, because if you look at what causes the transmetallation, which is, the gadolinium dissociating from the chain, it is more likely to dissociate in an acidic medium than an alkaline medium. And of course, CKD patients have metabolic acidemia. The half-life is long because their kidneys are not working, etc., etc. That's why more transmetallation happens. Now, when is a dialysis patient going to be most acidemic? Before dialysis or after dialysis? It's going to be before dialysis. So if I give the GADO before dialysis, maybe that is the worst time to give the GADO. All right. So again, we may do, but again, this is my speculation based on the biology. But that's what my radiology colleagues feel comfortable. So that's what I'm doing. I believe we have seen no cases of NSF since then. But I don't think it matters much whether I do dialysis, Tuesday GADO and Wednesday dialysis, or etc., etc. But I'm hoping we can get them to come around to stopping doing this. But it was a big step to even do gadolinium in dialysis patients, right? Because this was such a big scare. 15 years ago, 20 years ago, that it was a big step. So I think we will get there eventually, but in the GADO, we are even a few steps behind the iodinated contrast story. But
you really had affected patients, severely affected patients with the systemic fibrosis. So this was really, really true. Maybe a final question, because we in Austria also try with our radiology colleagues to have something like a consensus statement, and we heavily looked at, of course, what you wrote and on your diagram, and Sara already asked whether there was a change or less renalism. What we hope is that in the outpatient, in the extramural radiology sector, there will be less trouble, and patients have to come 3, 4, 5 times if the creatinine is not there. We are hoping this. So I want to ask you, did you see a change in the outpatient elective setting of radiology departments, so to say?
So the first author, Blair McDonald, is somebody who does mostly that. And he's very big on the logistics of it, because again, for me, it was learning, right? As a nephrologist, I don't know all the things that go into it. But your point is totally true, right? It may be an oncologist who orders the CT scan. It's a booking clerk in the radiology department who is booking it. And it's up to them to figure out, does the patient have CKD or not? Is there a creatinine or not? And all those, right? And then they call, and the oncology may not look at it in time. And, when do they send the information back? We have different systems everywhere. So this creates a lot of friction, a lot of nuisance, a lot of workload for no benefit. Right? Because there is absolutely, the risk is so low, and especially with CT scans. Like I'm saying, I saw one case in my lifetime. Why are we doing all this? So for CT scans, we said we stopped asking for a creatinine. And that's what these guidelines say. We just ask the patient, do you know that you have got kidney disease? Are you seeing a nephrologist? And patients often do not even know that. So I'm sure we are missing a lot of this, but that's fine. So we have made it as a very, very, we know the question we ask is just to pick up something that's really obvious. Otherwise, we are okay. We don't bother with asking for creatinine. The other thing we do is our previous guidelines had that if a patient gets a CT scan, a high risk, right, GFR 20, they get a CT scan, we would ask for a creatinine to be done 2 days later. Now, how does a radiologist get this arranged? Because they are not looking after the patient. They tell the GP or the oncologist or the internist, do a creatinine, but often it doesn't get done. How do you send information across? They don't want to order a creatinine, because if my radiology orders a creatinine, it will come back to them. And they will have to look at it and decide what to do. And I'm in not the nephrologist is not in that picture at all. The nephrologist only comes when there is AKI, and they get to, and we would come and blame them. Oh, you did not measure the creatinine, you bad doctor. So we decided to do away with that. We said, don't measure a creatinine. The risk is so close to zero. If the patient truly gets AKI, so we give a handout to the patient saying, hey, if you stop passing urine, you get short of breath, you get swelling in your legs, go to the emergency. That's it.
Okay.
No measurement of creatinine, which is a change, right? Because many places, like I was talking to Joel from Michigan, Joel Toff, and he was saying their center has this, it's a metric. How many AKI do you get after contrast? So they are forced by the hospital legal system to measure creatinine because they want to show that their risk is low. I think that's a waste of everybody's time. We have got things to do than measure creatinine. So I think your question is very apt. We have to really work the outpatient nuisance. As nephrologists, we don't realize how much of work goes into all this. So we got rid of most of it, right? Don't measure creatinine, don't ask for creatinine, don't measure it afterwards. But this is only locally, right? I have managed to do it at the Ottawa hospital by working, and they had to ask us, right? And we had to say, we had to give permission. As a nephrologist, as a radiologist, it's hard for them to say don't measure creatinine. It's like, oh, who are you to say don't measure creatinine? But as a nephrologist, I can tell them don't bother, and I won't blame you if something happens.
So
and nothing has happened.
So your telephone is always ringing now.
Yeah, so the outsiders do ask me, and I tell them, this is what we do, and please go ahead. And if you want, I can come and talk to you about this. But this is a big issue, right? And it tells you how much work goes into this silliness, right?
Are there any patients remaining in whom you would still recommend post-contrast media measurements of creatinine, like very advanced CKD, intraarterial, contrast media application, or would you say don't measure routinely at all?
So we do them, but these are patients that we see anyways, right? So they are in our advanced CKD clinic, let's say, especially in transplant, where people worry a lot in the kidney transplant population, where, even patients worry a lot about creatinine, where they are not going to be missed, right? But so we don't have to ask the radiologist to do anything. We are going to be involved in those patients anyways. And then it's up to us to say, hey, let's measure it. But with CT scans, we have done this, and I've not seen a single AKI in the last few years.
And I would love to come back to the issue of cholesterol crystal emboli. So firstly, with regard to nomenclature, would you include this into the definition of contrast-induced AKI? Because it's actually not the contrast, it's something else. And secondly, when do you search for this entity? When do you do additional tests? And what do you do? Is it like complement measurements or eosinophiles, or what do you measure on these people?
Yeah. So that's a great question. So I would prefer, again, right now, I'm sure there are patients that are labeled as contrast-induced AKI who are cholesterol emboli. I would say you should not do that, right? Because the contrast is not doing the damage. It's the catheter, the wire, which is dislodged the cholesterol emboli. Or some patients may even have spontaneous, right? A cholesterol emboli. So I would prefer that you call it something else. It is often a clinical diagnosis. So if you do find some associated, like livedo reticularis, if you see trash feed, you see eosinophils go up, you see hypocomplementemia, and you see a story that fits, somebody who has atherosclerosis elsewhere, they did have a femoral catheterization, then I'm and again, it's hard to say definitively without a kidney biopsy, but I say, hey, and the creatinine also often doesn't go up from 80 to 400, right? It will go from 80 to 120 to 160 to 200. It'll keep going up, right? Because often there is the direct damage from the emboli, which will make the creatinine jump. It's kind of a stepladder pattern. And then there's inflammation related to the microemboli, which causes the creatinine to go up further. And it's a progressive decline, right? So that's when, if the clinical story fits, then I say this is more likely to be cholesterol emboli. We have only biopsied a couple of times because of non-recovery, and it turned out to be, embolic disease. It's hard to justify necessarily doing a biopsy when you don't have a cure for what you're going to find and an intervention for that. But I think, overall, this is a point that is perhaps important outside this topic also. I don't think we do enough biopsies, at least here, in AKI. I think we should do more biopsies in AKI overall, right? Especially when patients don't recover at 2 weeks, say. We often label this as ATN and walk away, and they're dialysis dependent, but sometimes it may be AIN, sometimes it may be, some weird crystal or atheremboli or whatever. So there is some prognostic information that we may get. So I wish we did more. Again, this is a work in progress locally. I talk about it a lot, but hopefully it is slowly happening, because biopsies are not that risky, right? There is a risk with biopsy. I should not say, they are low risk. There is a small risk, but overall, I think in AKI, especially, even if we think it is ATN, I think it would be useful to do biopsies. And then we would also have a greater sense of cholesterol emboli. Again, I'm saying that, many of them are cholesterol emboli. Maybe they are not. But at least we would prove it. So I think your question is really important in that we should do more kidney biopsies in AKI.
And I have to challenge you with one further question from my part. So I found one paper co-authored by you last year, Dr. Koo, on the kidney recovery after contrast administration. And I was surprised to read, and because here the paper gives some idea that there may be some relevant damage by contrast media. And I thought by myself, what happened to Swapnil?
I knew you were going to bring it up. I did not talk about that paper at all. So this was the paper Gunnar is referring to is a post hoc analysis from the CA-AKI trial, right? So it was not a contrast dedicated prospective study, and I'm a co-author because I was part of the CA-AKI trial. The way I would look at that is, and I think the discussion does say that, but again, in the abstract, they are a little bit more dramatic to sell the paper. they report poorer outcomes in patients who got contrast as far as dialysis dependence is concerned. I honestly don't think so. It's possible that they capture those tiny sliver of AKI that can truly happen after contrast. Maybe a couple of patients may have been like that. I think they also mostly capture the other issues, right? Like if you have a sick patient in the intensive care units who requires 4 CT scans, they are probably sicker than the other patient who did not require any CT scan, right? So it's speaking, and that sick patient is hence likely to remain on dialysis, and the CT scan has nothing to do with it. Can you tease that out from retrospective? Again, though this was an RCT, the contrast is looking at it retrospectively, right? From that database where the adjudication wasn't as I would like it to be. No, it isn't. So yes, it is one of those papers that I can put there in the propensity score stuff saying, this is the other end, right? Like this is not telling you that contrast is bad. I think their message is not bad in the sense that if you've got a patient with AKI and you're doing a contrast procedure, you should think about it and not do it blindly, which is again, it's like common sense. Sure. I'm hoping the message from that paper is not seen as don't give contrast. It should be that think before giving contrast. Like take a pause for 2 minutes and say, oh, contrast is necessary. I'm going to go ahead.
Before switching back to Sara for her final questions, I would also love to say thank you so much for all your work in this field, and your Canadian recommendations are really so important. And I had a brief look into the new first draft of the KDIGO recommendations on AKI, which are openly available. And I definitely prefer your Canadian approach, which is much clearer on fewer pages than the KDIGO. But thanks so much, Swapnil. So back to Sara.
I have 2 more short questions. So being a fellow flozinator myself, I would wanted to ask you, what are your thoughts on SGLT2 inhibitors in preventing contrast-induced AKI?
Yeah, that's a good question. So there is, and this story is very funny, right? Because when Flozins first came out, the FDA, I don't know in Europe if that happened, we had a black box warning from the FDA and Health Canada saying, oh, the risk of AKI might be higher. And that was mostly, again, there were some case reports, but it was mostly speculation because, they are like ACE inhibitors, there is a GFR drop, maybe the risk of AKI will be higher. But then what we saw actually was that there was this observational data coming through that AKI is lower in patients who are on a Flozin. And then the trials also had AKI rates, and they were following it as an adverse effect. And all of them show overall that AKI is lower with SGLT2 inhibitors. And how do you even explain that, right? Why should AKI be lower? As far as again, this is all AKI, not just contrast AKI. There are many theories out there. One of the theories, again, and we don't even know how SGLT2 inhibitors actually do as well as they do, right? Maybe it's the TGF, maybe it is something else. One of the intriguing theories I had seen is, someone called them beta blockers of the kidney, because a lot of the oxygen consumption is in the proximal tubule and loop of Henle, and by blocking the channel, maybe you're reducing the oxygen consumption, and the medullary ischemia is perhaps lower. Again, I don't know. I'm not a basic scientist, but those hypotheses are really cool. I think the important lesson here, of course, is that you should not stop these drugs. And that often happens. There are all these sick day rules, which are mostly, to me, non-evidence based. So I think if a patient is on a Flozin and they're getting contrast, leave them on. If at all, I don't know strongly that how much contrast is reduced. AKI is reduced. Like I say, contrast is so low, it will be hard to show that they reduce contrast-induced AKI. But there are definitely kidney protective agents even in the acute setting, and leave them on. Don't stop flozinating.
Thank you. That's definitely important. We should be more confident in leaving these medications on. So maybe finishing up with the practical questions, because we often see patients who are really terrified of contrast because they've heard that it's going to damage their kidney permanently or they're going to have to get on dialysis. Given the shift in how we understand the risks today, how do you personally explain this to a worried patient?
So for CT scans, I'm very confident in saying that it's completely fine. Please go ahead. Do not worry about it. There are the transplant patients, especially, and those who are very close to dialysis, where they are very much worried. And like Marcus's point, right? Even if it goes from 7 to 5 and back to 7, when your GFR is 8 and you're very close to starting dialysis, that may tip things over. So in those kind of patients, I do talk about nuance, and we look really hard at the need for the contrast scans. But in the vast majority of patients, I tell them CT scans, don't worry. And with arterial contrast, often it is in the setting of somebody who has a therapeutic need for it, right? So if you've got unstable angina, or you need aortic valve implantation or whatever, there is a real true need for that therapeutic procedure. And that's what you have to weigh against whatever is the potential risk, right? So that's the kind of conversation I have. And my job, I look at my job as mostly is to sell the contrast, because I believe it is necessary. And it's my job is to hold the hand and say, it's fine. We are with you. And if something happens, we will take care of you. And to please go ahead. Because I think the low, very low, close to zero risk versus the real, benefit they will get from the intervention, it's like there is no comparison. The benefit you're going to get from the contrast procedure, especially, is so huge that, I put that in perspective, right? Again, I don't say it's zero, but I say, hey, we will take care of you in the very, very, very low likelihood that something happens. But with CT scans, I tell them not to worry.
Thank you so much. I think these are perfect closing remarks. Thank you once again for being on Markers at Home with us. It was a pleasure hosting you again. And yeah, we hope to be able to invite you back at Markers at Home very soon.
Awesome. We had a great discussion. Thank you for having me.